Welcome to a new episode of Medicine in 3 minutes. As usual, we go straight to the point. The subject is brilliantly made clear and often illustrated. Today's topic is about asthma. Asthma type, pathophysiology of asthma, symptom, and treatment. During this presentation, we will follow the next plan. Introduction, hyperreactivity, exogenous versus endogenous, pathophysiology, neurogenic inflammation, genetic and environment, cause, symptom, type, treatment, short versus long-acting beta-agonist, steroid, montelukast, anticholinergic, exercise-induced asthma, occupational asthma, breathing exercise, food to eat, food to avoid, asthma natural remedy. Asthma is a chronic but reversible airway inflammation. It is characterized by period of attack of wheezing, shortness of breath, chest tightness, and coughing. There is some hyper-response to trigger, including antigen leading to acute obstructive symptom by bronchoconstriction. There is a mucus plug and increased inflammation. Asthma cannot be diagnosed at the first presentation. Pulmonary function tests can be done from the age of 6. Peak flow meters are useful in the office for monitoring, called reactive airway. Asthma, it's a process of inflammatory, chronic inflammatory, with hyperreactivity, but reversible. It's episodic, and usually there is a history of early onset. Classically, we distinguish idiosyncratic versus extrinsic atopic, and there is some precipitating factors. There is a healthy airway. Here there is increased airway smooth muscle, and here asthma attack by contracted muscle. Asthma is the result of chronic inflammation of the airway, which results in increased contractility of the surrounding smooth muscle of bronchi. Exogenic is linked to genetic and environmental allergen and pollutant. Endogenic is linked to the nervous system. Among symptoms are wheezing, shortness of breath, chest tightness, coughing, and sputum is hard to bring up. Classically, before the age of 12, it's genetics. After 12, it's environment. Up to 40% of children suffer from rhinite allergic, and children are more likely to develop allergy if one or both parents have allergy. Allergy differ between adults and children. The respiratory system in children is smaller. The bronchi and the bronchiole are narrow, so even a slight decrease in diameter of this airway can have serious consequences. Many children outgrow their allergy. Atopy is the tendency to produce an exaggerated immunoglobulin E, immune response to the otherwise harmless substance in the environment. Allergic disease are clinical manifestation of such atopic response. Atopy may have a hereditary component, although contact with allergen or irritant must occur before the hypersensitivity reaction can develop. Maternal psychological trauma in utero develop atopy. Dermatitis, atopic dermatitis, rhinitis, and asthma. Triad of atopy. Then we move to physiopathology. Asthma is a multifactorial disease with a genetic component. Environment include allergen and polluant, plus endogenous factor. There is a cholinergic system and no adrenergic, no cholinergic nervous system, NANC. Inhibitor NANC, it's bronchodilatator VIP. Excitatory NANC is tachykinin bronchoconstrictor. Neurogenic inflammation, mast cell interaction with eosinophil, macrophage, lymphocyte, and epithelial cell. Eosinophil, they secrete cytoxin. This is an overview of the penetration of the allergen to go inside the lung, to bronchi, and then to the cell. Bronchial section will recognize the mucosal lining, the secreting gland, the bronchial smooth muscle, mast cell, the pollen antigen, and blood vessel. Mast cell receive the signal by three ways. The first signal goes to cytosol as primary mediator. The second signal goes to the nucleus as mediator for cytoxin. The third signal goes to mast cell membrane, phospholipase at A2 for arachidonic acid. Membrane phospholipid to arachidonic acid by the effect of phospholipase E2. Then from arachidonic acid to prostaglandin by cyclooxygenase, and from arachidonic acid to leukotriene by lipoxygenase. Prostaglandin, powerful stimulant of gland, leukotriene C4, D4, E4 are called slow reactive substance of anaphylaxis. It's 1,000 times more powerful than histamine. When aspirin acts in asthma, there is inhibition of cyclooxygenase and stimulation of lipoxygenase. Inside the mastocyte and the basophil, there is some balance between adenyl cyclase and guanyl cyclase. Prostaglandin E1 and E2 increase adenyl cyclase inside the mast cell and basophil. The increase of AMP cyclate by inhibiting the release of histamine. On the other hand, prostaglandin F2 alpha increase guanyl cyclase, and the balance go to guanyl GMP cyclic. When guanylyl cyclase is increased inside the cell, it releases histamine, slow reactive substance of anaphylactic, a puff and heparin. Symptom. The presentation of asthma, there is a tachypnea with rapid breathing, expiratory is prolonged, wheezing, accessory muscle, and with diminished breath sound. There is intercostal retraction, diaphoresis, pulsus paradoxus, exaggerated blood pressure with the respiratory cycle over 10 mm of mercury, which drop in inspiration. With X-ray, there is an increased clarity of the lung. There is increased intercostal space. Ribs are more horizontal, and the widening of coast diaphragmatic angle increase. Spirometry, pulmonary function test, measure lung function, volume and speed flow of the air inhaled and exhaled during expiration and expiration. Asthma is an obstructive syndrome. This is the normal curve, and this is the obstructive syndrome. There is a differential between COPD, cystic fibrosis, pulmonary fibrosis. Asthma with totally normal pulmonary function test, we do a challenge by bronchoprovocative cause as mini asthmatic exacerbation. For that, we give methacholine. Methacholine lead to drop in FVE1 over FVC, and methacholine challenge if pulmonary function tests are normal. Asthmatic with a pulmonary function test normal, we give methacholine to trigger a crisis. How to differentiate emphysema from asthma? Both have a syndrome, obstructive syndrome with FEV1 over FVC low. DLCO is low in emphysema, but DLCO is normal in asthma. Type of asthma: intermittent, mild, moderate, and severe. Mild intermittent 2/7. Mild persistent 4/7. Moderate persistent 7/7 with FEV1 16 to 80. Severe 7/7 with FEV1 under 60. Acute exacerbation, we start with oxygen. Then we give beta agonist, short action albuterol, methylated doser inhaler or nebulizer are equivalent, but nebulizer is best option for very sick patient in hospital. Anticholinergic less effective because long acting. They work better in COPD. Steroids spurt 7 to 14 days. In the chronology of thing oxygen is the first step. Next, fast-acting beta agonist, a third element is steroid. Remember, asthma is an inflammation. Taperin steroids spurt surge of 10 to 14 days as 60 mg per day. Steroids take 12 to 24 to see effect. After you resolve bronchoconstriction, you give steroid. Beta agonists don't resolve inflammation. Start intravenously, then transition to oral. Chronology will start with oxygen, then beta agonists, then corticosteroid. Mild, intermittent, twice a week. Pulmonary function tests are normal. We give only albuterol. Mild, persistent, 4 times a week, plus night cough. Pulmonary function tests are normal. We give albuterol plus inhaled corticosteroid. Moderate persistent, daily symptom, plus night cough, 4 times a week. But pulmonary function tests are normal. We give albuterol, inhaled corticoid, and salmeterol. Severe persistent, daily symptom, night cough, 4 times a week, but here FEV1 V1 less than 60. We give albuterol, inhaled corticoid, salmeterol, antidicotroyen montelukast. Chronic treatment, daily inhaled steroid, moderate dose inhaler. Treat asthma, which is inflammatory disease. Chronic asthma, inhaled steroid every day, but patients still have bronchoconstriction, beta agonist as needed. Long-acting beta agonists once or twice a day. Now used routinely. Indication are if patient has nocturnal asthma or for job constraints, lawyer in public speaking. Be aware of the risk of hiding the evolution of low noise. What is a nebulizer? Nebulizers are machines that turn liquid asthma medicine into a fine mist. This mist comes through a tube that is attached to a mouthpiece or face mask. But nebulizers take at least 5 to 10 minutes to get to the medicine into the lung, and sometimes even longer. Exercise-induced asthma. The airway narrows from exercise. Exercise-induced bronchoconstriction. Exercise does not cause asthma, but it is a trigger. There is a shortness of breath, elevated respiratory rate, wheezing, and paroxysmal coughing from an irritable airway. Examination may reveal a wheezing, prolonged expiratory phase, peak expiratory flow rate. In athletes, symptoms of bronchospasms such as chest discomfort, breathlessness, and fatigue are often falsely attributed to out of shape. Medication. Beta agonist 20 minutes before exercise. Inhaled corticosteroid, leukotriene agonist, mast cell stabilizer, montelukast, or salmeterol, 2 hours before exercise. Occupational asthma workplace. Sensitive and used occupational, it's immunologic inhalation of specific substance, including a high molecular weight protein from plant and animal origin, or low molecular weight like chemical, metal, and wood dust. Irritant and used are no immunologic with high exposure to irritant. Asthma inhaler contain a medication that treats the symptom of asthma. A spacer is a device used to increase the ease of administering aerosolized medication from a moderate dose inhaler. It adds space in the form of a tube or chamber between the mouth and the canister of medication. Food to eat. rich in vitamin C, green pepper, orange, tomatoes, kiwi, broccoli, berries. Food rich in vitamin E, like olive oil, almonds, spinach, and sweet potatoes. Food rich in omega-3 fatty acid like olive oil, canola oil, cod liver oil, flaxseed oil, and mustard oil. Onion. Food to avoid: dried fruit like dried apricot, alcohol, wine, frozen or prepared shrimp, food with high amount of sulfate, food that is allergic to your body. Thank you for watching this episode of Medicine in 3 minutes. Make sure to click the button like and subscribe. Your comments are very welcome. Thank you.